Good morning, everyone. Welcome to the Virtual International Symposium on Dignified and Compassionate End-of-Life Care, organized by the Action Research for Community Health Lab, Arch Lab of the School of Social Sciences, Nanyang Technological University, Singapore. My name is Dr. Andy Ho, Associate Professor of Psychology and Medicine at NTU, the chairperson of the symposium and the host of today's webinar. I would first like to acknowledge and express my most sincere thanks to the Ministry of Education of Singapore for the generous support of the symposium, as well as with the empirical research program on family dignity intervention that aims to strengthen evidence-based and holistic palliative care in the local context. I would also like to express my deepest appreciation for the Palliative Care Center for Excellence in Research and Education, PalC, for hosting the symposium, to all of our plenary speakers for their wonderful scholarly contribution, and to all of you, our participants, for your amazing enthusiasm and interest to this series of webinars that focus on understanding and supporting the needs of patients and families facing the many challenges of death, dying, and bereavement. My team and I at the Arch Lab had first conceptualized the symposium more than 3 years ago. And we have in fact originally planned for a physical symposium to be held in Singapore. However, due to COVID-19, which made physical meeting an impossibility, we had to be flexible and adaptive to develop a virtual symposium in a very short period of time. In fact, we reached maximum registration capacity within 2 weeks after we launched the post-symposium in mid-June. With overwhelming demand, we put in more resources to make more spaces available. That too was quickly filled up in just a few days. And this really goes to show the significance and timeliness of the symposium, as dignified and compassionate end-of-life care is of paramount importance to all human beings who one day will face their own mortality as well as those of their loved one. Every human being is born free and equal in rights and dignity. This is the first article of the Universal Declaration of Human Rights, the one major document that defines who we are as a species in relationship to our fellow creatures and with the cosmology of our worlds. Apart from being the defining virtue of our existence, the concept of dignity has also been a core principle that guides the practice and delivery of palliative, end-of-life, and bereavement care services around the world. Despite its importance, dignity is, after all, a complex and value-laden concept. And over the past 2 decades, researchers and clinicians have spent endless hours trying to unearth the constitution of dignity within the end-of-life care context, while developing ways to translate the concept into clinical practice so as to ensure that dignity can be protected and promoted amongst patients and family through care that accentuates empathy, kindness, and compassion. Over the next few days, we'll hear and learn from 4 of the most prominent and renowned scientists and clinicians who specializes in dignified and compassionate end-of-life care practices and research, along the continuous trajectory of pre-loss palliative care and post-loss bereavement care. Through knowledge transfer that emphasize evidence-based practice, as well as opportunities for clinical networking and collaboration, it is our hope that the symposium will create a positive paradigm shift that enhances and augments holistic palliative end-of-life care practices in Singapore, Asia, and around the world. The virtual symposium is divided into 5-part live stream interactive webinar featuring 4 distinguished speaker presentation and 1 joint panel discussion across 5 continuous days. On each days of the symposium, we will begin with a brief introduction and a check-in with a panel speaker. Thereafter, the speaker will present a 7-minute webinar followed by a 10 to 15-minute interactive question and answer session. All of you participants are encouraged to post a question on the Q&A window in your Zoom browser. You're also able to upvote question to your peers by clicking on the thumbs up icon on each of the questions posted. Due to time constraint, we'll only be able to answer the most popular question with the most upvotes as decided by all of you. So please do not miss this great opportunity to interact with our speaker, post any questions and reflection that you may have, and we look forward to this segment at the end of today's program. And today we're at day 1 of the symposium, and I'm most delighted to introduce our first panel speaker, Professor Elizabeth Lobb. Professor Elizabeth Lobb is Professor of Palliative Care, Allied Health, based at Calvary Healthcare in Sydney. She is an adjunct professor in the Faculty of Medicine at the University of Notre Dame, Sydney, and in the Faculty of Health, University of Technology, Australia. Professor Lobb obtained her PhD in psychological medicine from the Faculty of Medicine at the University of Sydney in 2001. She has worked clinically as a bereavement counselor and educator for over 24 years, In addition, as a behavioral scientist, Professor Lobb has worked in psycho-oncology and palliative care research for 23 years. She has established national and international research collaboration and pursued independent multidisciplinary clinical collaboration in oncology, hematology, clinical genetics, cancer genetics, and palliative care. Professor Lobb's passion for palliative care end-of-life research is motivated by a desire to provide enhanced evidence-based communication and dignified psychosocial care across the cancer continuum from diagnosis through treatment, remission, and survivor of relapses, palliative care, and bereavement support for families and caregivers. Professor Lobb has been an investigator on multiple comparative research grants totaling more than $16 million. And it's my greatest pleasure to introduce Professor Elizabeth Lobb to you today. Liz, can you turn on camera? Hi, Liz.
Good morning, Andy. Good morning, Andy. Good morning. Good morning, everyone who's registered for this extraordinary symposium, and thank you for all the hard work to put it through.
Yeah, it's great to have you, and it's our honor to have you speak to us. Just before we dive into your presentation, I think we're all excited to hear what you have to share. But I do want to check in with you because I haven't seen you for a long time. You know, we were supposed to meet in Singapore, but because of COVID-19, we weren't able to do that. So how's life in Australia right now?
We have been very blessed in our response to the COVID-19 pandemic and really very aware of the struggles that other countries around the world are going through. Life for me has not changed greatly because I am hospital based. I'm at work every day. Certainly back in March, April, when we were starting to put our pandemic plan into place, things were very challenging, very stressful. We didn't know what to expect. But I've been coming to work every day. We're being screened every day. We get our temperatures taken every day. So life hasn't changed greatly. Of course, socially, when we were in the lockdown period, like everybody else, I wasn't able to visit friends or go to cafes or music venues. So it was a very meditative, contemplative time, really, to be able to just not interact, to reflect on my thoughts and my work and what all my colleagues and other people around the world were experiencing. Yeah.
Mm-hmm. Yeah, I think we shared something similar in the sense that we are physically isolated, but we're getting more in touch with ourselves and getting more contemplative and reflective of what we're actually doing. Yeah. How has that affected your work in palliative care and end-of-life care, COVID-19?
It's been very interesting for me being an academic based in a palliative care hospital. And so I think one of the things that we've really worked very hard for, and we decided at the beginning of this pandemic, not knowing the severity, but we made the resolution that no patient would die alone. And whilst we've had to limit the visitation, even if someone needs to visit someone who is in the last hours or minutes of their life and they're unwell, we dress them in personal protective equipment, we meet them at the door, we escort them up. So we've tried our very best to make sure that people are able to visit when they need, and certainly that no one would die alone. We've had to implement very quickly, particularly for our community patients. What we have noticed is almost a doubling of the number of people who have chosen a home death. And we think part of this is due to perhaps some fear in coming into a hospital with the virus, but also we think more likely it's because they didn't want to be limited by the visited restrictions. So of course, if someone dies at home, and particularly in some of our culturally diverse communities where it's nothing to have 15, 16, 20 people at the bedside. So our community palliative care team have really, their load has been increased greatly, and we've had to look at, we still are fully occupied in our inpatient palliative care ward, but certainly our community services have increased greatly. Yeah.
Well, it's great to know that there's so much different measures in place to ensure that people are, have a greater sense of autonomy and control that really give their final days a deeper sense of dignity. And that's what we're here today too, to really talk about and dive deep into the concept of dignity. Thank you for sharing all of that with us. And I look forward to talking to you more after your presentation in the Q&A session. So without further ado, I would like to pass the stage to you for your presentation today on dignity, therapy, empirical foundation, clinical application, and patient experience in Australia. Professor Lobb.
Thank you, Andy. And now I will face the challenge of IT. Right, has everyone can see the slides? We're clear? Fine.
Yes.
Okay, let's get started. So thank you so much for the opportunity to present today. And this is a topic that is so close to my heart. And I think in these days of uncertainty, it is so important that as we move in the world, that we move with dignity and compassion. And this is in our own personal lives, but also in the interaction with our clients, with our patients, with our families. And so, of course, I can't begin this work without acknowledging the extraordinary work of Professor Harvey Trochinov, who I see as a mentor, a colleague and a friend. I first met Harvey when I was working in West Australia, and we were doing some of the very early pilot work on dignity therapy. I went to Winnipeg to spend some time with he and his team. I was privileged to run some dignity therapy training sessions for counsellors, social workers and clinicians. And really it's been Harvey who's been the inspiration for the work that we've been able to undertake here in Australia. And we were involved right through to the large international randomised controlled trial, and then some of the studies that have flowed out of that, which I'm going to present today. So we know that, let's start with some definitions. We know that dignity is defined as the quality or state of being worthy, honoured or esteemed. And there's been a lot of politicisation around it, particularly with the physician-assisted suicide discussion and the euthanasia movement. But it's so much bigger than this, so much bigger, and it doesn't relate exclusively to considerations around assisted dying. It really provides an overarching framework that guides doctors, patients and families to really be clear on what the objectives and final wishes and therapeutic considerations are that are so important to end-of-life care. So if we can broach these issues systematically with end-of-life care discussions, it allows our patients to make more informed choices, to achieve better palliation of their symptoms, and have more opportunity to work on issues around life closure, which is so important. And so we know that when we put this at the centre of our care, when the preservation of dignity becomes the clear goal of palliation, the care options expand, and it moves then beyond the physical symptom paradigm to much more psychological, social, spiritual, and importantly, the existential aspects of the patient's experience. So today I'm going to talk about three aspects of dignity research in Australia. Dignity therapy itself, the patient dignity inventory, which was developed out of dignity therapy, which I have now amended, and also the patient dignity question. So we know that the challenge that faces health professionals is how to address the suffering of patients with life-limiting illness, particularly in those domains that come from the psychosocial, spiritual and existential domain. And we know that there's been a huge amount of research, and my own hospice here are involved in clinical drug trials that focus on the physical symptoms, and there's been much targeted research both nationally and internationally treating symptoms such as nausea, shortness of breath, delirium, etc. However, the psychotherapeutic interventions that we can use with dying patients have not received as much attention, although this is certainly growing. We know that, for example, that Bill Breitbart and his colleagues found that spiritual well-being and meaning serves as a buffer against depression, hopelessness, and desire for hastened death among terminally ill cancer patients. We know that there is a link between depression and hopelessness, and this has also been shown to heighten a person's desire for death and suicidal ideation. My own Australian colleague here, David Kassane and Brian Kelly, both psychiatrists who work within palliative care and psycho-oncology. David Kassane defined what he said the demoralization syndrome, which consists of this triad of hopelessness, loss of meaning and desire for death. And so the work that's been done up until now and is ongoing suggests that any psychotherapeutic intervention that we target towards dying people must bolster meaning and purpose, and therefore lessen the overall suffering for this very vulnerable group of patients. And there are many therapies that are out there that have been used. Interpersonal therapy, group group supportive psychotherapy. We're doing life narrative and life review here in our hospice, cognitive behavioural therapy. So I guess it asks the question, so why do we need dignity therapy if we have all these other therapies that are available to us? And I think firstly and most importantly, it's grounded in very strong empirical work. In the very early studies, the pilot studies that were done by Harvey and his team, they interviewed patients as to what was the most significant things that impinged on their sense of dignity. So it was developed to directly address the concerns identified by patients. It was specifically designed to be applied to the most vulnerable. I know when I was working in West Australia, it was not unusual for us to be doing dignity therapy 3 or 4 days before the patient's death, and for that to be beneficial. It can be done at the patient's bedside, and we know from data that's come out that it can positively influence family bereavement after the death. However, and I will highlight this because I think it has perhaps attributed to not the strong uptake that we would anticipate in certainly many of our local health districts, is that it can be very labour intensive for the therapist. But I'll address some of those issues. It does have a theoretical framework, and it draws on some of those earlier models such as logotherapy, existential psychotherapy to bolster meaning, hope and mortality, life review, life narrative. But this is underpinned, and it's so important that we have a therapeutic approach to this framework. So the model's got 3 major categories, and this came out of the qualitative analysis in our interviews with dying patients. So their perceptions of what impinged on their sense of dignity related to illness concerns, what was defined as the dignity conserving repertoire, the language, and the social dignity inventory, and I'll speak a little more about those. So the illness related concerns were those that derived from the illness itself, and that threatened to or actually impinged on the patient's sense of dignity. So you think of perhaps a patient who's had a head and neck cancer and they're very disfigured, or a woman who's had a mastectomy with breast cancer, or you think of a patient with a fungating wound where there's a very strong odour. So these are concerns that relate to the actual diagnosis and illness itself. And then there's the dignity conserving repertoire. So this was divided into 2 themes. So these are the internally held qualities or worldview that the patient may have, but also to a variety of personal approaches or techniques that patients themselves use to increase or maintain their sense of dignity. And of course, the social dignity inventory component is one that is vast because it refers to the quality of the interactions with others, and that includes us as health professionals, but other family members, carers, our volunteers, that enhance or detract from one's sense of dignity. And so this inventory, this component of it, refers to external sources outside of the patient that may impinge on their own sense of dignity. So over 13, perhaps 20 years, because I went to West Australia in 2003 and we were already involved in some of the early pilot work in dignity therapy. So Harvey and his team has published some of the first empirical studies on this issue of dignity among the dying. And they examined the extent to which patients near the end of life were able to maintain their sense of dignity, and determined how various demographic and disease-specific variables related to this issue of dignity. It culminated after many months of pilot studies with really exciting, important data that we were getting from this. But of course, we know that if we want to go to the gold standard in research, that we have to go to the randomized control trial. And so this was funded from the National Institute of Health, and there were 3 sites in Manitoba, in Canada, New York, and Perth, Australia, which was us and which was me being involved. And it was a great honour to be part of Linda Christensen's team over in West Australia. In the international randomised control trial, there were 340 patients and carers participated, and they were randomised to 3 arms. There was the dignity therapy arm, the client-centred visiting arm, and the standard care arm. And this needed to make sure that, because dignity therapy itself takes about an hour, and so when you're doing a trial, you need to allow, because reviewers were saying, well, maybe the benefits were because you sat down and you talked to this patient for an hour. but we knew it was much bigger than this. So we needed to have other therapies that lasted a similar amount of time to be able to see what was it about dignity therapy that was different. We also followed family members for 6 months after the patient's death, and the goal was to assess the effectiveness of these supportive approaches to dignity, quality of life, psychological dimensions, and family outcomes. And there was a battery of questionnaires that were undertaken, and many with our ethics approval, we were allowed to have either the carer or the researcher themselves to help some of the patients complete these, because we need to be very aware of the fatigue that many of our patients experience. And so many of the measures were specially tailored to cater for that fatigue. So in the standard care, patients were able to receive the full range of psychosocial support and palliative care services to be offered in their facility. In the client-centred one, they got a visit and they were guided through a series of questions about just their general health and well-being. And then in the dignity therapy arm, they received 2 visits and they were guided through a series of questions to develop a manuscript which recorded their history, thoughts and feelings. And I'll talk a little bit more about that as well. Now, interestingly, despite some highly significant results in the pilot work, and this is why you do a randomized control trial, we found no significant differences in stress levels before and after completing the study in the 3 groups. However, dignity therapy outperformed the standard and client-centred arms in being helpful, improving quality of life, increasing sense of dignity, changing the way the family appreciates them, and being helpful to the family. It was significantly better than the client-centred care in improving spiritual well-being, so very important in addressing those existential concerns, and significantly better than standard care in terms of lessening sadness or depression. And so it was concluded that although the ability of dignity therapy to mitigate outright distress, such as depression, desire for death, or suicidality, was yet to be proven, its benefits in terms of self-reported end-of-life experiences supports its clinical application for patients nearing death. Here in Australia, and I won't have time to go into these studies, but I certainly urge you to look them up, and I can certainly provide some references through Andy. We've trialled in our pilot studies dignity therapy with patients with motor neurone disease, and it's also being done with residents in aged care facilities in Perth in West Australia. So I'm going to go quickly through it. The first stage is the interview, and there's a whole series of questions that have been developed specifically on the feedback that patients gave us. So such as, tell me about your life history, particularly the parts you either remember most or think are most important. When did you feel most alive? And this is around the generativity aspect of the manuscript. Are there specific things you want your family to know about you? Are there particular things you want them to remember? And this is where this really strong sense of dignity comes in, where you're seeing the patient as in the bigger role than the patient and their disease. So what are the most important roles you've played in the family, in life? Family roles, vocational roles, community service. Why were they important, and what do you think you accomplished in these roles? I can't emphasize enough the importance of the role of the therapist. And we know in all our therapeutic interactions that we need to be conducting these in the context of supportive therapeutic alliance, and this is understood. But our care tenor, which is the tone of care that denotes respect, empathy and support, is particularly important for these very vulnerable patients who are rapidly deteriorating. And so for patients, the undermining of dignity is highly influenced by the texture or tone of their care, and that includes our voice as well. Thus, a gentle, supportive, non-judgmental therapeutic stance is really important when we're doing the dignity therapy interviews. The interview is transcribed verbatim, and I know in West Australia we could turn these transcripts around overnight because we had the team ready to do that. And this is one of the challenges in the clinical setting, to have the workforce to be able to do that, although some centres here in Australia are using retired journalists to do the interview and transcribe them quickly. The editing process is undertaken by the therapist, and this involves putting things in sequential order, because sometimes patients will drift off and things will be out of sequence and the timeline won't quite flow. And they'll start a conversation and then they'll shift. And so it's our role to put it in a sequential order that makes sense and flows well. And so this allows patients to speak freely, knowing that this is going to be ordered for them and put in a way that any changes or errors of omission can be addressed later. So this is the last and the really important phase. We come back with the transcription and we read it to them. And it's usually incredibly powerful, emotionally evocative, and a really meaningful experience. It's almost like this person is hearing the story of their life. And then any opportunity for editorial change can be made. It could be big, it could be small. And we do this as quickly as possible because these patients, certainly in our trials, were towards the end of life. And we need this session to be as close to the initial interview as possible, because this is saying to the patient, this is important. We need to do this immediate. We need to be attentive because it reinforces the esteem with which their words are received. And this relates to the care tenor that I referred to, and the value that we're placing on their story, on their words, and on who they are. I need to point out, though, that dignity therapy is not for everyone, and we really need to be careful. And we had quite strict criteria within the clinical trial. But even now, it's not going to be helpful or supportive for someone who's got a significant psychiatric disturbance. Someone who has acute, severe psychiatric symptoms that would require individual treatment and medication managed rather than with a psychotherapeutic intervention. Anyone with an active psychotic mental disorder or paranoid ideation, it's not suitable. But however, patients who are on a stable regime of psychotropic medications or who are currently in individual or group psychotherapy are not necessarily excluded from dignity therapy. We haven't got the time, but there's the book. And I do urge those of you who really want to know more about the very layers of this important intervention to get a copy of Harvey's book, Final Words for Final Days, which will go through the whole process in much greater depth. So what are some of the clinical applications we've had in Australia? The first was the dignity inventory, and this was one of the measures we used for dignity therapy, and it's a 25-item measure of distress, and it came out again from the qualitative studies that patients identified. And one of our research assistants, when they were sitting helping the patient fill this out, for example, one of the questions was, I don't think my appearance has changed. I don't look the same as I used to. And patients score it from 0, no, this is not a problem, to 5, this is a major problem. And the patient scored 5. And our research assistant observed the partner who was in the room, turned to the patient, said, darling, you're as handsome as the day I first met you and married you. And so we started thinking, could the patient dignity inventory itself be used as a way of starting a conversation? And so that was how this study came about. It addresses 5 areas: symptom distress, existential distress, dependency, peace of mind, and social support. So here we decided to, and it is a valid tool that can be used clinically to measure the patient's sense of dignity, but we used it as a focus for a clinical interview to help communication between couples about distress and other issues relating to a diagnosis of advanced cancer. We didn't think that a one-off conversation was going to change a lifetime relationship of communication, but we wanted to open the conversation up to allow couples to feel more connected and open perhaps to a discussion of issues that were important to them. And we have published this study. We had 34 couples who were referred, and 12 consented and 9 completed the interview. So it wasn't easy. The oncologist would introduce the study to the couple and then ask permission to release their details to us. And often we would find we would ring them and the partner would say, oh, look, I would love to do it, but there's no way my husband would, or, well, look, we're really not interested, but we didn't want to say no to Professor. So hence the importance for us researchers really to be one step back from this informed consent process. But however, studies have shown that a 25% response rate in studies with these sort of interventions is pretty average, so we didn't feel too bad about that. So as I said, each item is rated 1 to 5 to indicate the degree to which the patient experiences various kinds of distress related to this. So it's either not a problem at all, which is 1, or 5, it's an overwhelming problem. And so first, the patient and their identified partner meets with a psychosocial clinician. We used a clinical psychologist, but it doesn't have to be. It could be a social worker. It could be a pastoral care worker. Important that they've had experience in working with vulnerable people. The patient fills out the patient dignity inventory, giving their own rating, and then their identified partner completes it, giving their rating. So they do it separately. Then the psychosocial clinician reviews the results with both of them, summarising the areas of where they agree and where they differ. And so for the items where this cutoff was greater than 3, which indicated that this was of some concern to either the carer or the patient, they then opened up to discuss these issues and determine whether additional psychosocial support was required. And the interview lasted about an hour, so it wasn't that time consuming, similar to a usual psychosocial interview that you would do. From the results that we found was that the focus of the interview was particularly acceptable for men. And this can be really challenging sometimes to have these gender-specific differences in engaging people in psychotherapeutic interventions. And the quote from this male really summarised, he said, "Because I'm not a great verbaliser, sometimes there's not the emotional language, I mean, for women and for men. But he says, because I wasn't a great verbaliser, the questions are kind of better and a bit more for me to use. It's somewhere to go, it's somewhere to start. So it's a sheet of paper and you circle your responses. And so you don't have to go searching for the words or the language. So we found that for males, it was particularly helpful. The other benefits were that it helped couples to express their concerns together. And some of the comments we got was it gave this real sense of pride, saying, we're on the same page. This is really good to see that I've got a fair idea of what whoever member of the partnership was the patient, what they're going through, and the patient had a sense of what the partner was going through. It was able to identify differences and understandings and allowed people, it gave them permission to speak about their concerns. It allowed them to be in control of the issues and to be part of the resolution by looking at a mutual understanding. I remember we had one couple and they stuck it up on the refrigerator at home with a fridge magnet, and they said, we're going to check this each week to make sure that we're on track and that we're communicating well and that I'm getting the right messages and understanding, you know, where my patient is at in terms of their illness. And this was another quote from a patient. The intervention to me was an eye-opener. And when I answered, actually, it made me more aware I wasn't being realistic, which was making it dangerous and more worrying for him. So that to me, that was a big change. Yes, I realised I had to be a bit more realistic about what I was doing and how I was coping with it. The next area that we then decided to explore was the patient dignity question. And this is a separate piece of research that Harvey and his team have done. And we introduced it here in our palliative care service, and it just has made such a huge difference. Again, looking at the personhood of the person, so of the patient. You know, we get a new doctor, a junior registrar who comes on the ward, and there's a patient, you know, on bed 27, and they will have their medical chart and they'll see, you know, clinically what's going on for them. But this allows the personhood, the actual person themselves, to be understood and to be known as someone who's quite separate and quite different to their illness. And so the term was coined because of the association, because of what patients know who they are and what's important to them, rather than exclusively in terms of their diagnosis or their prognosis. And the question is very straightforward. What do I need to know about you as a person to give you the best care possible? And do you know, people struggled with it because they're so used to being asked about their bowels and their nausea and their headache and are they moving and are they walking around, all their physical symptoms, that when someone actually asked about them as a person, they had to actually stop and step back and think about it because this was something that they just weren't familiar with. So what we did, so the evidence to this, let's go back to the empirical evidence. So the study that Harvey did, 137 healthcare professionals completed 293 evaluations of individual personal dignity questions. 90% of the clinicians indicated that they learned something new from it. 64% said they were emotionally affected by the response. 59% influenced their sense of empathy, and 44% that it influenced their care of the patient. So they concluded that it offered an effective way of eliciting personhood, enhancing patient, family, and healthcare experience alike. So in our study, we approached the patients about 48 to 72 hours after they admitted. Because when someone comes into our palliative care service, the admission is usually because of uncontrolled physical symptoms. We wanted to give them time for those symptoms to start to be managed, to settle into the routine of coming into the service. We would then approach them. We would pose the question, what do we need to know about you as a person? We would summarise the response, check with them that that's the message they wanted to give. We then sought their permission for this to be placed on their medical record and to be related to staff when we had our interdisciplinary meetings. So as well as talking about the phase and the rug, which are all symptoms of physical and performance status, we included the patient dignity question at these meetings. The participant again was given an opportunity to reflect, respond, ask for clarification, and then the rest of the conversation. And it was brief. This is a brief conversation. It's nothing like the hour-long that dignity therapy might take, but just to make sure that they were comfortable and it was a personalised response. It's really important that the patient dignity question is not meant to replace conversations with patients and families about their personal situation and what they deem important and wish to be known. However, it is a starting point for a conversation. For example, we had one man when we said, you know, what do we need to know about you to take better care? And he said, actually, I'm deaf in my right ear. So can you tell those lovely nurses when they come to the other side of the bed so I can hear them? But there were much more individual responses to that. We collected data from 2017 to 2018. And again, this really illustrates how vulnerable, how fragile, how unwell our patient population is. We had 372 new admissions. 67 of them were just too ill or imminently dying and could not be approached. 104 were confused or non-verbal, or perhaps too breathless, or just didn't want to answer the question. So we had about 87 patients, 43% completed. We got a huge amount of psychosocial information that wouldn't usually be available on medical records that was deemed important to them, about their family and things that involve the family, about their living arrangements, their previous employment, their hobbies, their interests, the ambience in the hospital. For example, one patient said, you know, ever since I was a little boy, I've been afraid of the dark. I've never been able to get over it. And would you mind just leaving my door open so I can see the light from the corridor come into my room of a night? I just feel much more comfortable with that. So small things, but things that can make such a difference. A lot around family. This gentleman, and that's not his real name, said, I'd like to see my wife happier when I die. I'd like to talk with my son, who's a surgeon in the UK. He's too busy at work to come down to Australia to see me. So as a result of this, our social workers, the amazing group of people that they are, immediately stepped into work. And we got an iPad and we made a call and we got the son, and the son was there in the room on the iPad to be able to talk to his dad. And so there were tangible things that asking this question we were able to do. So we did a Skype chat with the relative. We had volunteers to come and chat and play music, and the photo in the middle is a harp that we can bring to the patient's bedside that they can play. You know, someone wanted, one of our Greek-speaking patients wanted a CD player so she could play her Greek music, leaving the lights on at night. We also facilitated pet visits, which our volunteers organised for a number of our patients. So things that were really important to patients that you wouldn't get if you was looking at blood pressure, pulse, all the usual physical measures that we take. In terms of the staff, it facilitated better communication, and it gave them, as I said, psychosocial information that isn't usually available but was really important to their patients. It was reported at all of our interdisciplinary meetings, and even our rehabilitation wards have decided that they now want to implement this. We thought about whether we'd put it on the patient bed head. Someone suggested, why don't we write this and put it on their bed head? And we thought, No, because there might be personal things that people don't necessarily want everyone to know. Initially, of course, we had paper records, and so we made sure it went on the front page because it can get lost in all the other notes. But now that we've got electronic records, there's room, of course, for it to go and not get lost among all the pathology tests and results, because it's such an important piece of communication. However, as I said, it wasn't without challenges. It wasn't an easy question to answer. I emailed Harvey and, said, Harvey, I'm really struggling with this. What's going on? And he said, well, Liz, it's because patients are familiar with being asked questions about their medical conditions, but not necessarily other aspects. So you need to give them prompts to help them consider their answer. So that was really helpful. Some patients tired easily and just couldn't focus to answer the question, particularly for our patients from culturally and linguistically diverse backgrounds. Sometimes we needed an interpreter, and so we would use the telephone interpreter to do that. But for some of them, they felt it was just too intensely private. I'm here for my medical condition. There are things about me that, you don't need to know, they're private, and I certainly don't want an interpreter to know them. So we needed to respect that. And so I think it's really important that we focus, when we're thinking about dignity therapy or any of the interventions that we're doing, to what Harvey has said, that it would seem that the importance of dignity becomes most transparent when it's threatened or undermined. And he defined the ABCD of dignity. A stands for attitude, B for behaviour, C for dignity conserving care, and D is for dialogue. And so I don't know how I'm going for time, but I have a sense that perhaps now's the time to pause, Andy, and there might be some questions.
You have quite a bit of time left. We could also pause for some questions, and then we can resume your session. How would you like to do this, Liz?
I'd be happy to take questions and to comment on various aspects. I guess it might be helpful to know that we ran some workshops here on using the patient dignity inventory to facilitate communication between couples, and we developed a manual. And I'd be very happy for people who are interested in having access to that manual, which just guides them through the process on how to conduct that. Yeah.
Now, I was listening to your presentation, and I find it very fascinating that while the patient dignity inventory was really an assessment tool, you have transformed it into something that began a conversation with patient. Yes,
and this, as I said, was an observation that our research assistant made. Some of the, actually I spoke to my colleague David Kassane about this, because you may be aware David's done quite a lot of research, couples research, particularly around prostate cancer. And when I talked to David about this study, and he went, oh, Liz, he said, I don't know. He said, a one-off intervention, we wouldn't expect that would change a lifetime of perhaps not particularly helpful couple communication. And maybe you need to screen patients beforehand. Perhaps you need to screen for those who have the most difficulties in communication, or perhaps the most difficulty in their relationship. But we chose not to do that, and we really invited anyone who was interested in sharing and being part of this. It was challenging to get both couples, and so often either the partner would want to be involved and the patient wouldn't, or the patient would and the partner wouldn't. I should say I'm getting quite a lot of background noise. I think someone hasn't muted their microphone, just to remind people. Are you hearing that noise, Andy?
I'm okay on my side. I'm okay on my side.
Someone's just turned their microphone off. Thank you so much. It just comes through as static, even though I'm way down under in Australia.
Yeah, I hear you. I think even for the study that we're doing in Singapore, sometimes it is hard to get the spouse or the partner to participate. Sometimes we are able to get referral for the patient. The patient said, let's do this. And then we're trying to ask them, can you identify a family caregiver that wants to do this with you? And that has been quite challenging.
Yes, and I should say that this research, it wasn't just a bright spark I got in the middle of the night. I have to say, I need to give due credit here. The psycho-oncology group that we have here, run by Professor Phyllis Buteau, and I'm sure you're very aware of Phyllis's work, we had a concept development workshop, and we had the room full of clinical psychologists. And we said to them, what do you see are the most significant interventions we should be working on? what are some of the areas that you find most challenging in your work? And it was very interesting because they said, we have the classic scene of you have the couple in the room, and I'm not being gender biased here, but it's true. Often the wife will say, he just won't talk about it. It's like pulling teeth. I try so hard to start a conversation. He just won't talk about it. So I think it was really significant to find that going through this checklist where the issues were listed and you could then circle as to whether it was considered important or not, that men actually found this really helpful. So if nothing else came out of this, it may not have changed a lifelong of communication, but perhaps it allowed men to be more engaged in that really important conversation that needs to be held as life becomes shorter, physical needs increase, patients perhaps become a little confused and are less able to have meaningful conversations with their partner. And so we feel that it's very inexpensive, it's a relatively easy intervention to implement into clinical practice, and we feel that it has made a significant difference.
Liz, perhaps you can stop sharing your screen so that our audience can see both our face better. So to follow up on that question and looking at some of the list of questions that our participants have showed up, while dignity therapy, I understand that we need to be able to go through a whole series of training in order for us to deliver this and going under close supervision. But in terms of using the question from the PDI, can anyone do that? Or what type of special attention do we need to pay for someone to use those questions in a clinical setting?
Yep, and I think there's a couple of very good issues there. I think, as I said, with dignity therapy, it's time consuming. The interview takes about an hour. Then the person who's conducted the interview, it's audio taped. They go away, they transcribe it. They have to reorganize it into chronological order, print it out, bring it back, read it to the patient, go back and make changes. And I can remember saying to Harvey, I'm getting quite a bit of resistance because often clinicians don't have this amount of time. It's not inexpensive, in their time, but also in printing it out. Because what we did with dignity therapy was that we also printed copies for family members to be able to give to them. And we put it on special paper. If someone loved music, we put it on paper that had musical notes down. Someone loved their rose garden, we printed the interview on paper that had imprints of roses at the back. So I said to Harvey, I've had a lot of people say, well, why don't we just interview? Why don't we video the patient talking? And he made a very valid response to that. If we're talking about the dignity of the person, videos can be very cruel, and someone cannot look well. They can be jaundiced, they've lost a lot of weight, their disease can be shown on their face. And this is perhaps not the last memory that their family members may want. And so he was quite insistent that no, you can't cut corners on this, that it needs to be done as an interview. He was all, and I think it's really important, and Harvey was insistent, it needs to be someone who has been trained in psychosocial interaction with patients. We have in various states in Australia trained volunteers very carefully to do this. Harvey was pretty insistent initially that it be done by clinical psychologists. And in fact, it was called, I think, it had a different name because certainly in America, psychotherapy is perhaps embraced more strongly than it is in Australia. But he was very insistent that it was needed to be with someone who was experienced, because if a patient became distressed, you need to be skilled enough to handle that. And the other aspect of dignity therapy, that it's not a Pollyanna. This is, airbrushing someone's life story. It's warts and all, and if someone disclosed something that was hurtful, when we read the transcript back, we gave them the opportunity to change that if they wished. If they didn't, it was left in. And I can remember with one man that we did it with, in the interview, he said, oh, that good for nothing son of mine, he's never made any of his life, and I spent a fortune on his education, and really he's just not made anything. And when we read the transcript back to him, he went, oh, I don't want that to be left for him to hear. I think we can take that bit out. So there's the opportunity to do that. The patient dignity inventory, that study that I related to with the 137 patients, healthcare professionals, It's been published. The patient dignity inventory is available. You can print it out. Again, you need to have the skill to be able to facilitate. We used a clinical psychologist in our pilot, but we know clinical psychologists are expensive in the hospital system. Not that I'm saying that any other discipline is of less value, but hospitals look at dollars. They do, it's realistic. But really anyone who is experienced in having interactions with vulnerable patient populations, so our social workers, our pastoral care workers, nurses could do it. I mean, nurses don't often have the time to be able to do that. You know, the junior doctor could do it, the consultant could do it. In fact, it should be done as part of taking a clinical inventory anyway, let alone using it as an intervention to do anything else. So it's freely available. It was used initially, obviously, to assess the importance of dignity therapy, but it's freely available as a clinical tool to either have a conversation or to do it as what it's named, a patient dignity inventory, taking an inventory of what are the aspects at this moment that this patient considers is impinging on their sense of dignity.
Thank you for that. I think there's a clear distinction between using the scale itself as a way to assess, how the patient is doing, how he sees himself in the world, and using dignity therapy as a psychosocial spiritual intervention to support a patient's sense of wellness at the end of life. While the dignity therapy needs to be highly structured and it needs to be done in a very coordinated manner, the dignity patient inventory can be used as a tool for assessment. But nonetheless, both requires the person who is doing it to have that sense of curiosity, to display care tenor, and to be able to carry out a conversation that is meaningful to the patient.
Absolutely. And when we piloted our patient dignity question, which was our third one that we talked about, what do I need to know about you as a person? When we were doing that, I had a research assistant who was not involved at all in patient care on the ward. And so we felt it was really important to have someone who was independent, because the patient might feel more comfortable telling someone who's not directly involved in their everyday care. And I can see that really the patient dignity question is something that could be done by a volunteer. But what I think is important is if you're going to ask it, you need to do something with it. You're not just going in there because you're curious. What do I need to know about you? It's that last bit. What do I need to know about you to take the best possible care of you? And you can frame it differently, but quite often we had to say, I don't mean physically, and we might have to give us a few prompts, like, where did you grow up, or what did you do for work, or tell me about your family. And so sometimes we had to prompt, because as Harvey said, people are so focused on getting the questions when they come into hospital about their physical symptoms. But I could see that the patient dignity question could be done very well by trained volunteers. And it was our volunteers that actually carried out many of the activities, like providing the player for music, bringing the dogs in for a visit, and many other responses that we got. But the important thing was that it was shared at the multidisciplinary meeting, where in our facility, everyone goes, the doctors, the nurses, the social workers, the physios, the occupational therapists. And so the team gets a sense of this person, their personhood as an individual, and not their physical symptoms.
That is so important, because I think, we often strive towards multidisciplinary collaboration, but at the end of the day, a lot of the way that it's being practiced is mostly still medically oriented. The psychosocial component rarely gets integrated into the process of care or the process of care decision making. And what you shared with us is so inspiring, in the sense that, even a volunteer can have a say in the multidisciplinary team, and their experience with the patient get built into the plan of care for everyone to follow.
Yes. And I mentioned there's a team, particularly down in Victoria, where they have trained volunteers specifically to do dignity therapy. We quite separately have volunteers trained to do biography, and that is very different. And people say, but what's the difference? And I keep coming back to the dignity therapy interview is about aspects that patients themselves deem as most important that impinges on their dignity, whereas a biography is a wonderful and a beautiful thing to do, and we have trained volunteers to do that. But the people who are trained in dignity therapy, you need to be able to, as I said, have the care tenor to conduct the interview, to then the typing skills to be able to type it out, although there are transcription programs now, I know, for someone who's not very IT savvy, but to be able to read it back to the patient, to edit it in a chronological order. And interestingly, they've had a lot of former retired journalists say, I would love to do this. You know, I've got the writing skills. I can organise this in a way that it will flow nicely. It will be read nicely. And so it's very possible if, you know, if your hospital or your service says, we can't afford that, we can't spend that amount of time. I actually had someone here at Calvary, a young woman with a brain tumour, and she very much wanted to have this transcript available for her young family. And so her father knew that she was doing this, and the father said, you know, I'd really like to source some photos and put photos in with the manuscript. And it was just beautiful, and it was a way of involving the family in it as well. So when she'd done the interview and the transcript was read back and it was printed out, the father then was able to insert photos of, you know, when she was at school and when they were on holidays and various aspects about her life, which made it a much richer personal document for the family as well. So you can be creative with it. Yeah.
Yeah, that's also what we found in Singapore too, as I'll be sharing tomorrow with the group, that, you know, we've done some research in Singapore using dignity therapy as a foundation, but expanding it to include family members. And the way that we did our legacy document is really to engage the family, to have them to have input, to put in pictures, to put in, you know, even the pictures about the families, or even I think remember there's one particular patient that we worked with. He mentioned that one of his high school teachers was so influential in his life that he learned a lot from him. And we actually went online to try to search for this person's picture, and we found him, and we put it into the legacy document. And he was amazed that it was there. So that personalization provided a lot more richness and vividness to the intervention itself. One of the questions that came in was that. And we talked about this quite a bit too, is that while the intervention is important, the person who does it, it's equally, if not more important. And so the question was, can you, Liz, talk a bit more about the ABCD model, specifically about the C? What is the C for the compassion part? Yeah.
Sorry, remind me. Go back to my slide again.
The ABCD model of Harvey was A was attitude, B was behavior, and C was compassion, and D was dialogue.
Ah, right. So the C, the compassion.
Yes, the C. Yeah.
Sorry. That very much relates to, it relates to how you approach the patient, very much being sensitive to, because we know that our patients have good days and bad days. They have good mornings and bad mornings. You know, we may approach someone in the morning and they're just not well, they've had a bad night, they're medicated, and then we might go back in the afternoon. So the compassion component is being very aware of where the person is at and being in tune with that. So in how we approach them, how we introduce it, the language that we use, perhaps the gentle prompts that we give, the acknowledging that we may have to stop and come back the next day if the patient becomes fatigued. So it's been very much almost at one with the person, in sync with them. It's like a dance. I could describe it as a dance where you're responding to them and they're responding to you, and it becomes a very evocative, almost intimate exchange. It's not like an interview where you're just going next question, next question, next question. You know, there are lots of pauses, there's lots of time, and it's in the tone of your voice, it's recognizing where the person is at. And that to me is compassion, wanting the best for them. We also know, and coming from, I guess, my Buddhist background, is that the wing under compassion, of course, is wisdom. And so we need also to be discerning, to know whether this is appropriate for this person. Is the timing right? And so we need to have both. We need to have the compassion supported by the wings of wisdom. Yeah.
One question that has a lot of votes is the question there with regards to dignity therapy. Are there any studies that showed its effectiveness in Asia or even non-Western societies? Do you know any of that? Liz?
Oh yes, absolutely. There's a huge amount. In fact, almost every time I go onto the literature, someone else has validated it in yet another language.
Hmm.
So certainly throughout Europe, I, I I'm thinking Taiwan, but I could be wrong. But certainly the measures have been validated. It's being trialled internationally in many countries. Harvey himself has visited to help them set up the study. It's being tried in different settings, as I mentioned here, in aged care, in motor neurone, Barbara Bentley and her work in that. So no, it absolutely has. It's been trialed and validated in many other cultures and countries. Yep.
And to add on to that point, I just did a quick search on Google Scholar, which is not the best place to do research on, but nonetheless is a quick place. And you're absolutely right, Liz. There's a study that was published in 2020 from Taiwan that
Yep.
looked at the effectiveness of dignity therapy in end-of-life care patients in Taiwan. And they found that dignity therapy was indeed effective in elevating a person's sense of dignity and decreasing the sense of demoralization and depression. So Taiwan
Yep.
has done this. I think there's multiple research in mainland China who's also looking at dignity therapy. Harvey definitely went to Hong Kong and trained a group of clinicians there, and now we're doing this in Singapore. So there are various research around the world who has tried to use dignity therapy or different variations of it to really provide that very important psychosocial spiritual support for patients who don't really get this in the current stage of biomedicine and the way that a healthcare system is being run.
Yeah. And I wanted to make a comment. When we were doing the pilot work, and we were getting different results to what came out during the randomized controlled trial. And I can remember going to Sacred Heart Hospice at St Vincent's Hospital here, which is a very well established. I worked there in the 80s actually. And I was presenting it to a group of palliative care doctors. And I said, unfortunately, we weren't able to influence desire for death. I listed all the others and desire for death. And there was a palliative care doctor who's a doyen. I mean, she's very powerful. She's been around for a long time. She's retired now. And she stood up and she said, Liz, why would you want to, how did she put it? She said, people have come to this place in their life. They're preparing for death. Why would you want to change that? They're ready. They're ready. So the question was, we don't want to hasten the desire. So we weren't so concerned that didn't happen. People were ready when they were ready in their own time. And that they were preparing for it, and we didn't want to prevent their desire. Some people were ready to go. They'd had closure, they'd had conversations with their loved ones, they were prepared spiritually, emotionally, and so you don't want to stop that. You wouldn't want to, if that is, and again, this is about individual, about compassion. If that's where they are, well then this is what we need to be respecting. And so we weren't that concerned that was one of the variables we weren't able to change. Yeah.
The desire for death, because you can be absolutely in a great place and still have that desire. Because we found closure, we're able to, have, relationship has been mended, and it seems like it's a good time I'm ready to go.
Yeah.
Another very popular question that came up from the audience is that one of them said that how much did the spiritual outcome differ from patients across different religion? Have you seen anything regarding religious or spiritual outcomes?
No, I haven't. There are lots of other validated scales around spiritual care, whether there are studies that have been done on whether doctors or nurses are able to take what they call a spiritual inventory. And it's certainly Megan Best, who's a palliative care doctor here in Australia, did her PhD on this topic. And there are many other ways of assessing a person's spiritual needs. Where I am here at Calvary, we're very multicultural. We have 4 major language groups here. And we certainly need to be very sensitive to the different approaches of the different cultural groups. We try as much as possible to facilitate their spiritual guidance, their rituals, what it is that they may need, that our pastoral care people make that available. In fact, it's interesting here, the very first person to meet patients when they're admitted to our palliative care service are our pastoral care workers. And they fully respect that if someone, no, that's not for me, but they introduce, they bring a cup of tea, they settle them in, they orientate them to the ward, they introduce themselves to the family, they make themselves available, they hand out the leaflet on patient rights and responsibilities, but also they can do a spiritual assessment as to what do patients need, particularly at the time of death, what particular rituals, and we've had Buddhist monks and nuns come in for chanting, what do they need after the death in terms of preparation of the body. So we know that palliative care encompasses all of these aspects, and it should be as part of our everyday care of our patients that we're looking at these needs and that we're asking the questions. We don't assume, because we have differences within cultural groups anyway, but it should be part of what we provide in palliative care, that we're aware if someone doesn't want anything at all, or if they want a specific spiritual advisor, specific rituals. I can remember, and I think it was a Middle European patient, it was traditional at the time of death to have, after death, to have the body surrounded by lit candles. And because we have oxygen cylinders, of course, on the ward, to have a room full of lit candles is obviously not what our occupational health and safety people would be happy with. So our pastoral care workers went and got those beautiful LED light candles, the battery operated ones. And so we were able to amend and adapt, but still to be able to have the ritual within the facility to where the people were. So I think in terms of spiritual care, yes, it's an aspect of dignity therapy, because people will talk about the importance of spirituality in their life, the importance of the spiritual rituals, whether they've gone to mass every Sunday, whatever has been important to them. But it's not the focus of dignity therapy, but I think spiritual care should be the focus of the care that we're delivering in palliative care. And it's one of the many aspects that we look at, because we talk of palliative care of being the whole care of the person. Yeah.
And to add on to that, I think dignity therapy really is looking at the personhood of the individual, the meaning in life, the purpose in life, and that can be a much broader understanding of what spirituality is.
Yes.
Apart from the religious connotation, there's just who I am as a person in relationship to everybody else.
Yeah. Yes, absolutely.
Yeah. The third most popular question that came in is about advanced care planning. So as Liz, as you know, advanced care planning has been a big thing in Asia. In Singapore is one of the most highly funded type of public policy in healthcare. It's probably a big thing in Australia and in Canada and Australia and US. And the question was, can we actually tie dignity therapy together with ACP, advanced care planning, in Singapore and other places?
Yeah, look, certainly advanced care planning is hugely on the agenda here, particularly in the days of COVID. We need to be very clear of what people's wishes are. We had an outbreak in a nursing home here, and there was a big conversation about whether these very, fragile, vulnerable people with multi comorbidities should be admitted to intensive care. And people were saying, well, of course they should be. Take them out of the aged care facility, put them in the intensive care unit. But these people had prepared their advanced care plans. This isn't what they wanted. The nursing home was their home, and that's where they wanted to die. So certainly within COVID, it's been very much the focus. I think with dignity therapy, which is why I think it's important that it's someone who has an experience of psychosocial interaction with patients. If in the course of the interview in dignity therapy, in talking about aspects of their life, that someone makes a statement about what they would want and not want towards the end of their life, with the patient's permission, of course, that can then be passed on to other members of the team so that they can become aware of that. There are very formal documents on advanced care plans. There's the language we're very careful about. We call them advanced care plans, not directives, because we know that people can change their minds. We've had a real struggle in getting them uploaded into the electronic medical record because there's that fear that once they're there, it's like carved in stone and you can't change them. Whereas if it's on a bit of piece of paper, you can add to it and keep writing it and throw it away and write another one. So there has been some concerns. But if aspects of the, someone may be talking about their life, how they've lived their life, and then talk about how they would envisage their death. We would assume that if someone was in palliative care, that they have already considered the option of resuscitation or going into intensive care, and it wouldn't be appropriate anyway. But there may be aspects of their plan that they may disclose during the interview that, with the patient's permission, the interviewer could pass on to the social worker or to the treating doctor, so that they can make sure that that's recorded in other aspects of the patient's notes. Because obviously the dignity therapy interview is not going to be sitting in the patient's medical record. There might be a note that they've completed it, but it's a confidential document. It wouldn't necessarily be shared in their notes. So it may come up in the conversation, which again, I think highlights the importance of whoever's delivering it to understand the nuances and the ethics and the consent processes in having permission to pass that information on if the patient considers it's important that their treating team needs to know that. Yeah.
Right, and absolutely right. I think from our experience in Singapore, when we're doing the family dignity intervention, so a family version of dignity therapy, issue about end-of-life care often comes up naturally. Yeah, because we're talking about what the person wants, what their needs are, and even talking about their stories and what do they want for their family, their idea of what they want for their own care comes up naturally. I think, for me, I think it'll be because our experience in Singapore is such that it's actually quite difficult for patient and family to talk about care initially. Like it's if you dive completely into medical decision, it's really hard for them to talk about it. But if you begin the conversation by asking you as an individual of who are you, what your needs are, what do you want for your life, then that naturally progress into a conversation about end-of-life care. But of course, being able to understand the ethics behind it and to ensure that the information is being passed to different members of the team in an ethical manner, that's critically important too. And tomorrow, for Grace, who asked about how can I do this in Singapore, I'll talk a bit more about that tomorrow.
Great. Great. Yes. Yeah.
Grace also asked about, can dignity, for example, you talked about the PDI were conducted between couples. Can it be done between parents and children as well?
Someone asked me whether there was a pediatric version of it, and I actually passed this on to Harvey, saying maybe this is something we need to think about. It depends when you talk about parents and children. So assuming that it's the child who's the patient, because this is about the patient. So what aspects does the patient consider important? If it's a child or an adolescent under 13, so not at a legal age, and the parent, we talked a lot about whether it should be a partner, so we did it with the patient's named partner, or whether it should be a friend or a neighbour. But it needs to be someone who's intimately involved in their care, because it's questions about their pain, their nausea, their mobility. So it's got to be someone who's reasonably intimate and familiar. So it could well be done if the patient was a child and they were able to express their needs and they're communicating with their carer, who is the parent. Yes, I think that's possible. As I said, this conversation was facilitated by a psychosocial clinician. So it would require a different approach, I think, because we need at the same time to value and respect the dignity of the child and their rights and their wishes and their privacy. And so I think, reminding ourselves it is a therapeutic intervention. So it would need to be, what's the word? Facilitated. So you have to have a facilitator for this conversation. It's not simply a tick a box and then saying, yes, I agree, or no, I don't agree. The therapeutic aspect of it is when you compare that and then you start the conversation about the differences. So look, it would be possible. You'd have to use slightly different language, more age-appropriate language, I think. But yes, yes, it could be used. Yeah.
Kelly asked that for patients who cannot verbalize, their life experiences, for example, people who are may have a trachea or they're dealing with other condition that prevents them from verbalizing their lives, can dignity therapy still be done?
I guess I draw on the work that Barbara Bentley did with patients with motor neurone disease, because for many of them, particularly at the later stages of the illness, they're unable to communicate, and many of them have communication boards. So it depends what's available and what's able to be used. Certainly, it doesn't require so I should have put a slide in showing it. I was so conscious of the time, and I know I get so passionate. I thought if I put in X number of slides, I'm going to talk twice that. So I sort of was a little bit economical with my slides. I'm sorry. I should have put a slide up that actually showed you the questions. But it's a matter of indicating the number. So if someone had a trachea or was non-verbal, they could point to the number. Our MND patients, because they had a communication board, could actually have the inventory itself up on their communication board. So yes, it is possible. I guess that, even if someone was vision impaired, you just would read the question out to them. So it is possible to be adapted and to work in with the physical, whatever physical impairment may be present. Yes. Yep.
And to add on to that, in Singapore, we did have when we were doing the RCT in Singapore, we were able to work with someone who couldn't speak. And because in dignity therapy, we actually give them the questions a few days beforehand. So they have time to read through them, they have time to reflect on them. And what we did with that particular patient is he actually wrote it out. He actually wrote his answers out. And we spoke with we have a family meeting, and the spouse was there, and the spouse helped him read out his responses, and the spouse also add on her viewpoints. And that enriches the experience a lot more.
Yeah. Oh, sorry, I just realised I was answering your question on the dignity inventory, not dignity therapy. Sorry. Yes, with dignity inventory, it's an inventory and you can circle numbers. Sorry. Dignity therapy. Certainly Barbara was able to do it with MND patients, and I guess this was because they were able to put their responses on their communication board. It would, yes, certainly dignity therapy, I'm sorry, I didn't mean to confuse people, would be more complex for someone who wasn't verbal. The inventory itself certainly could be done, yes, distinguish those two.
Kelly asked that whether dignity therapy, this is another person who asked, Tan Sui Lee asked if their dignity therapy can be applied for patients with mild dementia or even depression.
Yes, certainly it's a little different when you're doing, an international randomized control trial. And we had to address a number of the ethical concerns, obviously, to the funding body. And we had fairly strict criteria. And as well as the ones that I read out, which were the very clear psychiatric indications against it, we did, for example, mini-mental as part of the research protocol. I'm not that fussed on a mini-mental. I think if I was having a bad day and someone asked me the questions of the mini-mental, I don't know whether I'd get them right. So it's not the best test of cognition. But for someone who's mildly depressed, yes, of course. It's the severe psychotic psychiatric conditions that it's not recommended. Similar, I guess, to meditation. Someone who's having intrusive thoughts, psychotic episodes, it's not going to be helpful to get them to meditate and go inwards. So if you're doing dignity therapy with someone that, by the near nature of it, you're asking them to reflect on their life experience, to choose their words, it isn't going to work for everybody. Someone who's mildly depressed, you would want to make sure at the end of it how they were, because you don't want them going away feeling more depressed. And I guess that again ticks the box for while it needs to be someone who's reasonably experienced in doing this. As with any intervention that we do as part of the whole ethical process, we need to make sure that we do no harm. And so we don't want any of our interventions to leave someone worse than when we walked into the room. And of course, we know that, and so many comments we get from ethics committees when we go to do studies, but this is going to cause distress. The person's distressed anyway, and it's been found that to be able to verbalize, to cry, to put words to the emotions is in fact in itself therapeutic. So the fact that there are tears because of whatever intervention you're doing doesn't mean that it's caused harm. But what you need to be able to show is that because of our tenet of do no harm, that if there's a concern, and certainly we would always provide a contact number within our palliative care service, it's easy. we can say, if this has caused any distress, there's the social worker, there's the pastoral care worker, there's your doctor, there's one of the nurses on the ward. So there are opportunities. If you're doing it in the community, we would always make sure that we had a contact number for people. So we just need to make sure that what we're doing doesn't increase distress. But, it's for some of them, when I was in West Australia, in reading back the transcript was incredibly powerful. And for family members, and I'm sure you'll talk about this tomorrow, huge levels of emotion, getting insight to their mum or their dad or their sibling that they knew nothing about, or experiences of their life. And we need to acknowledge, I've talked about the vulnerability of our patients, but we need to acknowledge their resilience. And when we were doing this in West Australia, it was an older population. We had people who'd come through a depression, people who worked on the land, had been through drought, had seen cattle die. But we also did it with people who had 3 or 4 babies die, who had a sibling killed in a farm accident. And they were able to talk about this and to reflect on it. But at the same time, at the end, as we were closing the interview, to talk about how, despite these earlier setbacks in their lives, the comment that we got so often was, "Oh, but it's been a good life, despite this." Or they'd tell a story of incredible hardship, and then they'd say, "Oh, but the best thing that ever happened to me was the day I met my wife and she turned my life around," or "when I first looked at my baby boy's, eyes, whatever else had happened in my life, I knew that this was the most precious thing." And so these are the jewels, these are the wonderful experiences that patients are able to express. And it's not about their weakness, their fragility, their vulnerability. It's also about their resilience, their strength, their ability to rise above these and to make a life. And sometimes not. And it's, their story is their story. And that's the importance of the compassion, of the tenor of the person delivering it, that this is your story, warts and all, the good or the bad. And if at the end of the interview, a person can move to a place of, this has been really helpful looking back, I've done pretty well, I'm happy with my life, that's great. But if they don't, that's okay too, because that's where they're at and it's their story and it's their life. Yeah.
Thank you for that. I think we have a tendency as healthcare providers, we always want to make people better. But sometimes it's just a reality that it doesn't get better, and it's okay with that. Yeah. To have that opportunity to reflect and articulate about your life itself is meaningful for people. Yeah.
And to, if necessary, provide the opportunity for them to have a conversation later on, if they wish to, with a social worker or a psychologist, if there's time. For the certainly for the randomized control trial and the pilot work, we did it very close to death. I think in the last 2 weeks of death was the criteria, because we needed to pick a timeline for the design. So, of course, the design of a study for a randomized control trial is different to how you might do it in real life. So there may be some people who are doing dignity therapy earlier on in the disease trajectory, and that's fine too. But it's also possible to do it very much towards the end of a person's life, and that can be suitable as well. Yeah. I always remember when I trained as a bereavement counsellor for many, many, many years with Mal McKissick, he would say to me that in grief therapy, it's not the time to do psychotherapy. And in end-of-life care and palliative care, this is not the time to be doing Jungian or Freudian psychotherapy. People don't have the time, the energy. That's not what's important. It's about what can be most supportive at this time. Yeah.
And I think that's also the uniqueness of dignity therapy and the related intervention, is that it's very focused, it's very brief, and it can be done on the bedside of the patient. And knowing that patients don't often have a lot of time left.
Yes, that's right. Yeah.
We have about 4 or 5 minutes left. I think there's one last question that potentially we can answer, and this is from Meng Yi, who asked that under the context of COVID-19, given the challenges that's happening with social distancing and physical distancing, can dignity therapy can actually be done given the climate that we're faced right now?
Yeah, no, being realistic, we have nearly 300 volunteers here at the hospital, and in mid-March we had to stand them all down, and they haven't been able to come back. Many of them are 70 or older, which places them in a vulnerable group. We also want to limit exposure to our patients and to our staff. As staff ourselves, we're only able to meet in groups of 2. So all of our meetings have been cancelled. We do a lot of Zoom. So a lot of things that we would normally have, like our music therapy, our hydrotherapy, we used to have a high tea in our palliative care ward once a month where family members could come and we'd have tea and cake and scones. And unfortunately in COVID times, we've had to restrict a lot of the interaction. We screen everyone who comes in. We've had to limit access to patients, also to protect our staff as well. So I would think that there's probably a lot of, many of our psychologists are doing telehealth. There's been a huge increase in telehealth. So that's still happening. It's not as if people are being abandoned, but we're being very careful about people coming into the hospital who don't have to be there, you know, so staff and direct visitors of patients. And so a lot of those interventions, our biography service, we thought we could do it on Zoom for a little while, but we found that we couldn't. What we have introduced is iPads for our patients so that they can have conversations with family members. Because, of course, in Australia, we have border restrictions. So Queensland's closed its border, West Australia has, South Australia has. The planes aren't flying, so family members haven't been able to come. So we've been able to work with that by having iPads so that they can have conversations with family members if they're able to. So sadly, in the time of COVID, no, and we've had to restrict a lot of contact. And a lot of our services, our outpatient clinics have stopped, elective surgery has stopped, although we're starting to open up again now. But it's been a very difficult time for everybody, really. One of the things I'm working on at the moment is a very large grant. There's been a call within Australia looking at mental health and wellness within COVID-19 pandemic, and they're wanting data to inform their pandemic plan. And what I'm most concerned about is people who have been grieving in isolation. So people who haven't been able to be present at the death. We have restrictions on the number of people at funerals, so who haven't been able to perform rituals. We know that social support is so important when people are grieving. Lack of social support, we know, is a risk factor for bereavement. And so I'm planning to do a national study to see if we can get some sense of whether people who have been bereaved during, and not just during the lockdown, because if someone died in January and we had a lockdown in March, they would still very much be in the early stages of their grieving. So we're wanting to get a sense of how people are going, given that social contact, ritual, being present, being able to say goodbye is so important for bereavement. And how has this happened, and how has this perhaps impacted on people who are grieving? So I think that's a very important question that's going to come out of this, and hopefully we can inform any mental health plan going forward in the pandemic, or God forbid there should be future ones, so that we are prepared to and see if there is a risk within the population for adverse bereavement outcomes. Yeah.
And I think to follow up on that, I think it's important that we do need to plan ahead. You know, COVID-19 may not be the only pandemic, and hopefully there isn't more, but you know, the reality is we're becoming increasingly more vulnerable to different viruses. And if physical distancing is going to be a new norm for us, we need to be able to find more creative ways to provide psychosocial care using virtual platforms like this.
Yes. Yeah. And I'm so glad I didn't use lots of slides, because I think our conversation has been much more informing. I hope more informative to your audience as well. So it's been a real privilege to be here this morning and to have this discussion with you, Andy. Yeah.
It's a great pleasure to have you. Yeah, it's lovely to see you, and we're not done yet, because on Friday we're going to come back for a panel discussion, and on that time we're going to have more questions, going to talk more to our participants. So it's been a wonderful pleasure. Thank you so much, Liz, for your time, and we look forward to seeing you again on Friday.
And please, everyone, take care, go well, be kind to one another. Bye-bye.
Thank you, Liz. Thank you.